So our first speaker is going to be Helen Milner.
Thank you very much. First, I just want to say what a huge privilege it's been to be here for the last hour. I mean, how amazing has that been? So informative and so inspiring. And I think it absolutely sets the stage for a brilliant day. So much of what we talk about when we think about solutions, so Good Things Foundation, we're a digital inclusion charity, national, and we also work in Australia. And so much of what we do when we talk about solutions, and I'm sure the same is true around health inequalities, is that we have two choices. We have long-term sustainable change, and we have the safety net where we catch people before they fall. And I think most of you today probably understand that you're doing both. And I'm sure with health, that is such a massive, massive issue because around prevention and cure. So what we do at Good Things Foundation, we produce this thing. I know you can't read this. It's called Digital Nation. Digital Nation 2024 is the one in my hand. And what we do is we collate the key facts and stats about digital exclusion in the UK. So 8.5 million adults lack the very basic digital skills to do anything, really, on the internet. We have 2.5 million households can't afford mobile connectivity, and 1 million households plus can't afford any kind of connectivity whatsoever. That obviously, I'm not telling you anything, you know this because you use the internet every day, that if you are not online or if you can't use it, very important, digital exclusion is not binary. You're not online or offline. There's lots of shades in between. You're excluded from jobs, from benefits. We know people are being sanctioned because they don't know how to use the internet to keep in touch with their work coaches. So obviously, as Sir Michael has been saying, is that if people on very, very low incomes get that income taken away, then obviously that's going to have a massive detrimental impact on their health. We also know that 33%, it says on here, 33% of people who do not use the internet find it difficult to engage with the NHS. So actually, what we're doing is that people like me, I love technology, I love digitization. It makes my life really easy. I can buy my car insurance on a Sunday evening. I can go shopping when it's raining. But actually, that it's so fundamental how people who are online, who decision makers, how governments make decisions about how digitization is going to change and improve services, especially public services, without actually providing a proper, sustainable, long-term solution to underpin that. So at Good Things Foundation, we work both at the hyperlocal level and at the national level, creating solutions for that, a national data bank where we have free mobile connectivity for 500,000 people, a national device bank where we take old devices from people like NHS Trust, 25% of London, councils, businesses like Deloitte, and we refurbish those and get those into the hands of digitally excluded people. And most importantly, we are in partnership with thousands of local community organisations, libraries, charities, food banks, Virgin Money stores, to help people to get access at that point of need for this safety net that we're creating. But bringing those together, you're then creating the pathway for them to get jobs, to be able to get more money, to be able to connect with friends and family, for them to be able to access public services. And we've been told to be short, so I'm just going to finish with one story about Florence Mabel in Stockport. She's a wonderful older lady who, with the local partner, she got a free tablet computer, free mobile connectivity, and support from a local digital champion volunteer to get online. You know, her most favourite thing she liked to tell everybody was that her daughter had emigrated to Australia 25 years ago, and she'd never seen her face talking to her for those 25 years. So that was the biggest and most important thing that Florence Mabel told us. But the other interesting thing about Florence Mabel is she used to go to see her GP once a week. because she was lonely. She definitely did have a range of different health conditions. But once she got online and once she could connect with other people through the internet, she didn't go at all, hardly. She just went when she actually needed to. So we had a similar story with again, an older woman in Doncaster, and we estimated just the benefit of her improved health, reduced medication. Just the reduced medication was a saving of £5,000 for 1 year because she got online. So when we talk about digital exclusion being a social determinant of health, it's because it underpins so much of that poverty that Sir Michael's been talking about. But actually, we know that the stats also are these stories of individual people who have gone on to vastly improve their health. And one other number I like is, I don't know how many of you have been looking at the Alan Milburn Pathways to Employment Commission in Barnsley. If you haven't, you should definitely look at it. So this is looking at economic inactivity in Barnsley. So what's the biggest determinant of economic inactivity for working age adults? Health, exactly, poor health. 70% of those people who are economically inactive in Barnsley want to work, but there's no flexible work available for them. But also, if they tell the job centre that they want to work, they change their benefits. And then all of a sudden they have conditionality, right? So the benefit system is absolutely broken when we look at this. In the UK at the moment, economic activity is 78%. If we move it to 80%, for England, if we move from 78% to 80%, that is a £23 billion saving for economic benefit for the economy.
That's the whole, the 20 billion whole, right there.
23 billion, you've got 3 extra to play with. So if you actually focused on these people, and the reason I'm interested is because lots of these people are digitally excluded as well. They don't have the skills, they can't afford the connectivity, they can't afford the devices. Just shifting 2% brings 23 billion. So I just have that number in my head because...
Where have you got that number from?
So, as I said, you should read the Milburn's Commission,
report. Okay,
Pathways to Employment, and I actually think probably Marmot Places are probably addressing things in a very similar way to how Alan Milburn has put together a point of concept, proof of concept, pilot for Barnsley. So I'm sure they should become a Marmot Place, by the way. So I think that it's absolutely fascinating. But I'm hopeful and optimistic. So if we have a mission-led government who understands that you cannot do these things in silos, and if we all work to deliver our work and our policies in partnership, then surely we should be able to create that joined-up action that will not just make people's lives better, not only improve their health and their mortality, but actually bring that money into the economy so that we can, fix the so-called black hole and be able to invest in all of the things that I'm sure everybody in this room wants to invest in.
Great. Helen, thank you very much. Actually, I'm from South Yorkshire, so perhaps the whole of South Yorkshire could become a Marmot county. What do you think?
Well, we're working with Sheffield.
Okay.
Yeah. And they're close. We've got the 2 universities working together and the mayor, so we're very close.
Very good. Yeah. I knew you must be. Thank you, Michael. Right, we're going to have questions afterwards. We'll go to Brad now, and Brad, you're the founder of ALIKE and vice chair of the National Academy for Social Prescribing.
I am.
Yeah.
So I think like everybody in this room, I'm incredibly passionate about health, equity, society, community, and making sure people can live their best lives. As a result of that, by the way, I have chronic time blindness because I have ADHD. So if I talk too much, please just cut me short because I can talk for hours on this.
We've got a problem with a few people like that.
Well, please be direct with me. Just tell me to stop and I will. I do as I'm told, typically. I am a gay cancer survivor who created a charitable company. Alike has been founded to end loneliness and isolation caused by a cancer diagnosis, and we offer an iOS and Android peer support platform to anybody who's 18 and over diagnosed with cancer throughout the UK. It's been on the market now for 2 years, still as a minimum viable product. We've been doing proof of concept, and now we've just entered a partnership with Milner Cancer Support to scale it across the country. I'm incredibly passionate about this work, but what I wanted to do is frame it. I can speak about cancer and loneliness and all of the amazing initiatives that I'm a part of, but I wanted to frame it around money. Like, funding has been discussed today. And if we're talking about digital and we're talking about health and we're talking about services, let's talk about health tech products. So in venture capital, in 2022, in the United States, of the 2.1 trillion pounds of startup funding for startups, 0.5% went to LGBTQ plus founders. Closer to home, here in Europe, 2% of startups that given VC funding were women-led. 3.5% were black. An Access to Funding report backed by Forbes in 2023 found that disabled founders are 400 times less likely to receive VC funding. So if we're talking about digital equity and talking about equality, we have to look at the source of where these tech products are coming from and who's backing them and who's supporting them. And it's one of those infrastructure problems. How do we then enable LGBTQ plus founders to get the education, to get the tools, to get the skills, to put them in situations where they can learn more about the problem, to provide a service to their community? It's an education thing, it's a housing thing. Like, equity stems beyond health in our society. So we don't really, I mean, unless anybody here has a spare 3 million under their seat that we could give to a startup, I'm not so sure what we can do right now with that market, but I think it's about recognizing that communities do have the solutions. I didn't set out, when I was going through my leukemia treatment, treated in Imperial, Hammersmith Hospital, where I had my stem cell transplant 5 years ago. Professor Jane Appley is an absolute legend. I was in my hospital bed for 3 months, felt my lowest, and my treatment was absolutely incredible. It was 5-star. I was in a leukemia center of excellence. I had all of my questions answered. I had my family, fortunately, come and visit me, my friends, and yet 2 a.m., I'm still feeling lonely, I'm still feeling isolated. How do I not have an outlet? How do I not have a space where I can share this raw emotion? In 2020, and it was 2018 then, we live in a digital world. We communicate through people through our phones, in the palm of our hand. How can I not find somebody that's my age with my diagnosis in my area for someone that I could speak to? And I was able to speak with people, to share it, to then get to where I'm sat right now. I'm called an entrepreneur, but I'm not. I am making this up as I go along. But the way in which I've been able to do it is by sharing it with people like you. By sharing it with people like you, getting feedback, figuring out where the opportunities are, and people like you helping accelerate me and put me in front of people that do have the money, that do have the data, that do have the insight to get something to market. So I wanted to frame it in that way, that money makes the world go round, and if we're really serious about digital equity, we have to really be challenging the private sector as well as the public sector to fund initiatives that can help communities in a meaningful way.
Well, thank you very much. Thanks for sharing that with us. Thank you. Saira.
So I'm the lead for digital health at the Institute of Global Health Innovation and also work as a respiratory consultant at the Trust. We've been working lots on all types of NHS data over the past couple of years and how we can get fair value back for the NHS data that we have for all citizens of the UK. And we've done 2 policy reports based on that. But post-pandemic, some of the really shocking things that Ara first mentioned at the beginning of this session really highlighted the inequities in care. And through the COVID pandemic, what we saw that we, really quite terrible inequities in terms of populations that suffered more than others through the pandemic. And this should probably not have been, a surprise to any of us in the room, but clearly that showed up. And one of the reports that we chose to do after that was looking at data-driven technologies and how we can better improve inequities through using these technologies. And what we've discovered is everyone talks about AI, digital technologies, this is a holy grail, this is going to improve all of our lives, which I'm sure it will, and it's definitely the next step forward. But what we often see is that we're not addressing a lot of these inequities that come up over and over again. So certainly, through the pandemic, we saw the huge disparities in care and certainly the poor outcomes for certain populations. But what we also saw, that data was brilliant and really helped push things like the recovery trial and helped, with the vaccine and also treatments as well. And what we see now is the way that we use technology to improve access to care, to improve delivery of care, and also outcomes as well. So certainly using telehealth, using remote diagnostics, it's massively improved. And I think the digital divide is improving, but certainly we've got a huge way to go, especially when in NHS organisations, Wi-Fi doesn't even work properly. Then we've got, the potential of what we can do with data-driven technologies and certainly the massive amounts of data that we do collect and collate. So certainly looking at population level health management, looking at more vulnerable communities, looking at more inclusive trials when we're looking at drug trials, etc., and also looking at more rare diseases as well, how we can use better data to serve more underserved populations. And then looking at the prevention agenda as well, looking at more at-risk communities, how can we help that better using data? However, back to, I think, Brad's point right at the beginning was, how do we make sure that we have a diverse range of stakeholders that are kind of working in this space from the R&D side, but also in the kind of development and deployment side as well? How are we using and collating data to make sure that we've got an excellent data set that we're basing anything off? How do we narrow that digital divide again, but also what do we do in terms of post-deployment as well, making sure that we're not creating more unintended consequences. And these are all points to be addressed. So I think huge things that we can do with data-driven technologies, but I think one of the things that we need to make sure is that we are, creating these for all segments of the population, especially for those who have been historically underserved, and making sure that we're not worsening inequities as we go forward.
Great, thank you, Saira. Okay, so please be ready with your questions. If you raise your hand, somebody will come to you with a microphone. But I've got a couple of questions. Helen, you spoke about digital exclusion, which of course is a theme that's running across the three of the talks we've heard. What's the estimate of how many people digitally excluded in the UK, and how many people does your project reach?
So there's 8.5 million is the number that I tend to stick to.
People who are digitally excluded?
Yeah, because there's 8.5 million people who have no or very, very, very low basic digital skills. And because we know there's a massive overlap with people who lack basic digital skills and poverty, then the people who lack the access are also very likely to be lacking the skills as well.
Yeah.
Having said that, we do see young people who do have some skills. Let's not overestimate how much skills that young people in poverty have, but who have absolutely no money. And so, for example, the National Data Bank that we have, we see young people who come in who literally have no money and to whom we can give a SIM, and then they're online, and then they can apply for work and do the things that they need to do. So there are some people for whom it is only money, but the majority for people, that's why I use the 8.5 million number.
Okay,
Yeah.
but does that include children as well? 8.5
No, that's just adults.
That's adults only?
Yeah.
Gosh, yeah.
In the pandemic, so this is where some of the good stats came from around children, when children needed to do homeschooling, in the poorest families, 25% of the families, this is not children, the families, 25% of them did not have internet-connected devices to do homeschooling. 25% of them. And so the overlap between poverty and digital exclusion is absolutely huge. Because people think it's all about older people. It is often about older people. So a third of older people, so over, I'm going to say 65, but it does get worse, obviously, as you get older, do have some form of digital exclusion. But the research that we've done, there is still a massive overlap between those older people and poverty, because we know a lot of older people live in poverty as well. So that it just exacerbates, if you've never used it at work, you never did it at school, and also you have very low incomes. And also people tend to live in communities. So if you live in a low-income community, then there'll be lots of people in your community who are digitally excluded, right? And therefore it is the norm. It's not, it's not that, it's not like my mum, for whom, she's got 4 kids piling tech on her all the time. So that this is about understanding the kind of family unit, the community unit, so within those communities as well.
Okay, thank you. Well, perhaps we'll come back to this.
Sorry, you asked a question. So 1 million people is our target for the 3 years, 2022 to 2025. We're looking to exceed that. So that's why I like working in digital exclusion, because probably, unlike health inequality, I think we can fix it. The
it's something very
divide
pragmatic.
is narrowing, but it's deepening.
Yeah.
So the people who are left behind are left further behind, and then all of those social determinants around health inequality and other forms of complexity around poverty then exacerbate.
So you're getting to 1 million of the 8.5 million?
In 3 years.
You're doing a lot, but there's still a lot to go. Yeah.
But yeah. 8 times 3 is 24, right? That's a long time. It's too long.
We need to move faster.
Yeah.
Thank you. Brad, when it comes to VCs, I guess you've got an issue, because all the VCs I've ever met, except one, have been white middle-class men. The one I know is an Asian middle-class man, probably a very similar.
And there's nothing wrong with that.
So what are you going to do?
I think it's about accelerators. So I'm part of the NHS Clinical Entrepreneur Programme.
Yeah.
And then Professor Tony Young done incredible work in really amplifying the voices of clinicians and believing in clinicians that come to him or come to the programme with an idea that makes sense. And it's one of those things where as opposed to my learned colleagues here, a lot of my contributions are going to be anecdotal, so please hope you excuse me. But I think
so-called learned people are full of anecdotes.
I feel that there's a generalization that people from minorities have to be perfect to be able to get money from VC fundings. Where there's many examples in Forbes and in history where people have taken kind of a half-baked idea and ended up getting hundreds of millions of pounds worth of investment. And I still think that's true today, whereas the Clinical Entrepreneur Programme flips it on its head and bring a concept to us, even if it's a small idea, and we will help accelerate it with you. And even if it doesn't end up being what you want it to be or the vision that you had, we will help you pivot. And I think that's really special, and that's happening within the NHS environment. I think the NHS could go a step further and restructure slightly and put it on the statute books that it's enabled to actually invest in these companies, because the NHS doesn't have any infrastructure to be able to actually take equity to these companies. And I think it's missing a trick, because what happens is these companies then, like London in the UK is such a hotbed for technology and for innovation, but these startups are then moving to the US, where they then get investment and become multi-million pound, hundreds of million pounds companies. And I think the NHS is really missing it.
So the NHS should invest in.
I absolutely think it should.
I'm just imagining the headlines in the Daily Mail.
Oh yeah. Well, I mean, once you've made it in the Daily Mail, you've made it. I'm going to be in there one day.
That's don't have that as your
Tinder
ambition.
for cancer patients. Let's just do that. Yeah, exactly. So I mean, once you've made it the Daily Mail, you've made it essentially. So
okay, I beg to differ. Okay, thank you. Saira, when it comes to trials and data, clearly there's a big issue, because the quality of what you get out is only as good as the quality of what you put in, and we know that trial studies, they're skewed to a particular population.
Yeah.
When you spoke about inclusive trials, what did you mean by that? What does that mean?
So it's actually identifying patients that would be able. So I mean, basically, as a clinician, to select patients who are suitable for a trial, there's usually a poster on a wall somewhere, and it's like, oh, remember, if you see so-and-so between this age, I mean, it's a terrible way, and this is how you never kind of move trial inclusion further. But certainly kind of opening it up to other people, or trying to look at databases to see which patients could be appropriate for trial selection, and actually using things like the NHS app for people who are using it to see if that's, you know, another appropriate way for inclusion in trials as well. So I think it's identifying, reaching out to patients, and then having them, you know, having an option for them to be included in various trials as well. But at the moment, our kind of paper-based system is so far behind that we are not going to catch up in any
So it's kind of new strategies for recruiting participants into the trial.
And then looking at, you know, data itself for, you know, anonymised data that you're using in trials as well. Like you say, we're only ever going to be as good as the data that we collect. So it's not even the data collection, it's the data collection, curation, making sure it's clean to be used. So in the NHS, we're absolutely brilliant at collecting data. We spend hours and hours doing it, you know, whether inputting it or doing audits or whatever else, but actually using it in a way that is appropriate and has, you know, good outcomes for people. We're not as good at doing that. And part of the issue is some of the data is not that great, and what we are collecting. So again, highlighted through COVID, was around or ethnicity data at the point of vaccination. So, you know, we realised that actually there was a huge shortfall, and then the whole kind of terminology of Black and minority ethnic communities, but actually what is beneath that, a huge subset, but we were completely missing that. So there was a huge disparity in what we were actually collecting, what's missing from records, and actually what then is appropriate to use. So actually being better at the point of collection as well, utilising it in a much better way, making sure we're cleaning, curating it as well.
Great. I mean, actually, Ara spoke earlier about the data he used in his trial. I think when I was speaking, he didn't mention it, but when I was speaking to him before, we asked him about race, and he said, well, the data aren't really there even now. So that's
I think it was the King's Fund that did a report just about the gap in ethnicity data that was being collected. So then, you know, that has huge implications in terms of how we can identify populations at risk. And, you know, again, through the COVID pandemic, we saw that playing out, you know, terribly for people. Yeah.
Good. Right, I'm going to ask you all a question about AI before we finish, so be ready. But questions from the floor? Yeah, right. Yeah. Could we have a microphone, please?
Of course, it was at the back, right?
Thank you. Lisa Hollinson, British Red Cross. So it's a question around collaborations and how we help and support people and how we embed some of that support in the work that's ongoing. So we provide a lot of support and services for people in their homes who have health problems and need support with social care. And our biggest improvement, I think, in digital inequality is how we can embed that support into the work we do every day. So it's not a separate service, it's a support to the people who are going in and out of people's homes. So how can we build that support to people that can make such a difference? Because we know for things like virtual wards, we've supported North East North Cumbria to double the amount of people on their virtual wards. So people can be helped, but we need to organise it to embed it in some of the work we do already.
Thank you. Let's take that question, then we'll come to you. Who would like to take that? You're passing it on to Helen.
I mean, it's very tricky because that it's very much like you said, it's about embedding. So is that like the easy bit is the access bit. I mean, you can easily put connectivity into a house and you can easily give somebody the equipment. But how do they then use that and be confident to use it in a way and be safe, using it safely, in a way that is what they want to do? Let's make sure that people have agency. So, and this is also very important from a digital inclusion point of view, is that they have agency to do the things they want to do. So all of those examples I gave you, at the foundation of it is actually often about human connection. But then that improves their health, and that improves their socialisation, improves their volunteering in the workplace, improves their ability to get work. So I think that we always talk about, looking for the Trojan horses, looking for where's the thing that somebody can do. I also don't want to underestimate if people have complex health conditions, if they're aging. So we know dementia actually reduces people's ability to use technology. So I think in making sure that I guess always start with the low-hanging fruit, start with the people who are most receptive, for whom affordability is possibly their biggest barrier, and then work from there, but always understand that it's not about making somebody use the NHS app. This is about understanding their own personal motivations, and then from that build their understanding, build their skills, build their knowledge, and then they'll be able to use things like, I don't know, blood pressure machines or something.
Thank you very much. Did you want to ask a question?
Thank you. First of all three of you, Helen, Saira, and Brad, incredible projects and incredible work. Thank you. Helen.
Do you introduce yourself?
Oh, yeah. I'm Geeta Nagund, Red Cross, and also I'm a consultant gynecologist. I was just, my interest has been gender health gap, and particularly access and outcomes for women from BME background. We know the problem with the BME bit, but we're trying to improve data collection on that. In your digital exclusion numbers, are you collecting particularly those from these backgrounds, and also for women in particular, because we see that with the work we do now, that so much digital exclusion comes up, and particularly in antenatal care with the digital red books and all. Are you collecting that information, and what is it looking like? And also you mentioned 33% of those who do not use internet have problems accessing. Are they do not use or do not have? Or is it a combination?
It's both.
Both, yeah. Thank you.
So 33% of people who are offline, so that's neither use it nor have it, find accessing the interacting with the NHS difficult. So that is the stat. And Digital Nation 2024 and all the sources are all on our website. That's the best way to find all of those sources. So yes, we do collect data with a massive, the problem is that we don't want data collection to get in the way of delivering support. So we collect some data, but then we also follow that up with surveys and more intensive evaluation. And within Good Things Foundation, we have 6 what we call group outcomes. And they are that people are digitally able, equal, and safe, so that they are healthier, happier, and better off. And then below that, we collect baskets of outcomes that we can then aggregate up. Within healthier, it's one about things like accessing services, but it's also about how people feel. So do they feel healthier? And so, again, all of that is available on our website. I just want to say that the one thing, I'm smiling because it's ironic. We actually worked with NHS England on a digital inclusion program called Digital Participation, and it finished in March 2020. So just at the moment when actually people needed digital inclusion to support them with their health, actually that program closed down. But the good news is we have a lot of really great data.
What about the data on women?
Yeah, so we collect data on women and on, I was going to say in other specific groups like homelessness within the digital participation program, we collected that data. Women is a really interesting one because they live longer. So, at the moment. So the data, we also need to factor in age, which I think is really quite complicated. And also we do a lot of work with women from mixed ethnic backgrounds. And so, again, we have some rich data about that as well. So we do have different data. But it is very complicated because of the age profile and also the other socio-demographic profiles as well.
Okay, thank you for that. I've got 3 more questions. So keep your questions brief, but also keep your answers brief, all right? So we've got a question there, one in the middle and one on the left. Yeah. So we'll take the one here first, yeah.
My name Narendra Malanandan, I'm the National Clinical Director for Neurology at NHSE.
Can you hold the microphone near to your mouth?
Sorry, Narendra Malanandan, I'm a neurologist and National Clinical Director for Neurology at NHSE. I was really interested in the reflections you just made and just wondered if you could comment on the intersection between disability, poverty, and digital health exclusion, and being aware that often these patients are in families where they've got unpaid carers and so doubly affected from an income perspective, and they need much more expensive equipment to be able to access services.
Okay, they're all for you at the moment. Intersection between
yes.
disability
25% of people with a disability or a long-term health condition are digitally excluded. And again, I'm sure you know all about the other forms of intersectionality, that people who are disabled, only 50% of people who are disabled have employment. So therefore, that drives poverty. As you said, you've got unpaid carers who are crudely put in this economically inactive box. So yeah, absolutely. It's a huge area, and I think that the reason why I'm obsessed with Alan Milburn. My team will tell you that I'm obsessed with his commission. But because if you can find a pot of money, then that's the end of the rainbow, and then we can make sure that we're doing that work. And I think that picking out that people who have disabilities and long-term health conditions are absolutely people of working age, want to work, and there is absolutely no ways that the benefit system is helping them to do that, and employers are helping them to do that. So actually bringing that collaboration together, then we could, and we know that actually people in employment are more likely to be healthy, and that's not just about money, that's also about other social interactions and other support systems that they then are able to access.
Good, thank you. I think what I suggest is continue the conversations over coffee. Question in the middle.
So it kind of follows on from the last one, actually. I'm Zora Jaffrey, I'm a GP in Derbyshire, and I've got an interest in neurodiversity, autism and learning disability. So sort of specifically, it was what is being done and what do you think could be done to improve digital inclusion, particularly for patients that have a learning disability?
Okay. Does anybody else have a view on this?
Yes.
Brad?
I mean, what else could be done? I think I know that there's a lot of initiatives that have been founded by people who are neurodiverse, and it's also creating, in a very similar vein as to what I've contributed, creating an environment where people who are neurodiverse can achieve their best, especially as entrepreneurs. That's what the NHS Clinical Entrepreneur Programme has really tried to do, that instead of following this pathway, which is quite typical, there's different pathways for you. So I know there's quite a few technology products in the works that are geared towards these communities. The problem there is we talk about software, but it's hardware. And I think that's where government policy comes into it. It's accessing hardware. And I think there's policy that can be done around helping, I wouldn't say mandating, but definitely asking more private sector companies to provide hardware to schools, and there's examples of that happening, I know, in the Northeast. So I'd say, yeah, I think it's a mixture of providing the product through accelerators and then also government policy.
Great, thank you. Anything to add to that, Helen, very quickly?
This is just taking liberties with your question slightly, but because you're a GP, a GP practice in Birmingham set up a pop-up data bank, so where they gave out free SIMs. They used their tech service to text all of their patients to say, if you can't afford connectivity, we'll be able to give that to you for free. They had a queue before they opened, and then they had a queue after they finished. There was so much demand in that deprived community in Birmingham. And so it's just to say that this is about sticking plasters, it's about safety nets, but linking into things like the National Data Bank. I said we have 500,000 SIMs. We can get as many as we need for people who need them. So understanding how to work in partnership with national charities like myself, and we'll plug you in to local charities as well, and local organisations who'll be able to help people if it is affordability. That's their challenge, but also with skills. But what Brad said is absolutely important. I think with children, it's about that personalised learning, isn't it, as well, and making sure that this is an opportunity that obviously technology often enables that personalised pathways, so particularly for children with neurodiversity.
Okay. Thank you.
I do
Sorry,
have-
go on, yeah.
I have a quick example on that of,
Yeah.
and it's not really around just neurodiversity, but it's around hospital appointments. So, and it's an example of public sector, private sector, and charitable sector. So there's a company called Deep Medical who have developed an AI algorithm and machine learning that predicts hospital non-attendance, and they've trialled in Mid-South Essex NHS Trust, and they're now rolling out to 10 other NHS trusts. They have predicted it, I think, up to a 96% certainty. It's an incredible, the founder is a friend of mine, it's an incredible initiative. But what they're doing is, okay, so you can't show up to your hospital appointment, and the machine will predict when somebody won't show up, and it will give you the determinants as to why. It's like this person may be a single mother, and they booked a hospital appointment at 4 o'clock on a Monday. It's like, well, they're not going to show up to that hospital appointment because they have children. They may have just booked it because they were in a rush and they did the 8 a.m. rush and they just booked whatever appointment they could get a hold of. So the machine learning will then tell the hospital and then will rebook it to a time that's convenient for them. But this is where Uber now steps in. So Uber are now providing free hospital transportation through this partnership to those people to get them to the hospital, because it's not just about their time, it's also about access. We, as we work with the cancer community, provided support on their participation strategy. So it was a nice mix between private sector, Deep Medical and Uber, NHS appointments and the NHS Clinical Entrepreneur Programme and trusts, and charity sector in giving access to patient participation and patient behaviours. That's a really good example of how everybody can work together, because it's not just about digital and the access, it's all about the inequality and time.
Good, thank you. Right, quick final question, sorry, and then we'll wrap up.
Thanks. That was an amazing example, thank you. My name's Alice Deasy, I'm also a GP from Sheffield, and I'm a health inequalities lead for our network, which is very deprived, richly diverse, and a high number of non-English speakers. I've been really frustrated recently because there's a real push to get GP surgeries to move to online digital triage, and our GP surgery that I work in has resisted it. It came with financial incentives, and we didn't get the benefit of the money because we thought it was really going to increase inequalities and access problems for our patients. How can we persuade policymakers to think about these things before they put out policies like this, and how can we kind of encourage proportionate investment, universal proportionate investment in the right directions in order to try and get these things into communities like ours? Thanks.
Very good. Linking the two of a morning session together, excellent. Who's got thoughts on this? Saira, you got any thoughts on that?
I mean, certainly all the kind of
The batteries are done here.
maybe you should go.
Oh, actually,
Okay.
if I come closer, here.
Okay, Brad, do you want to, is there any, can you answer that question?
So what was the question? Sorry.
How can we persuade policymakers to invest in this?
So we have this through, so it's, again, from experience, I'm Vice Chair of the National Academy for Social Prescribing, and we've put a lot of time, effort and energy into building up an evidence bank that proves that social prescribing does in fact work. There is a massive data bank on our evidence bank on our website. If anybody wants to take a look, social prescribing works. On engagement with ministers, it's just that return on investment. It's just, it works. It cuts down waiting lists. It makes people feel better. You don't have to spend as much money on medication in the long run. There's a wide variety of examples. But it's just that return on investment, but then asking them to be a little bit bolder, like just asking them to really to take the risk on it as well. How have I done it in the past? I'm trying to condense it really quickly because it's been years worth of work. Evidence, it's a hearts and minds approach, essentially. So evidence, make sure that the evidence is there, but then also pull on the heartstrings a little bit. It's just like, it's important for communities. Who's advising them to say no? And why are they advising them to say no? And that's one of the big ones. It's like, what are the advisors telling them and why are they saying no, and how can we challenge that? If they're only speaking to people from a certain class or for a certain demographic and they're only getting that advice from those people, then actually speak to the communities that could really benefit from this policy or from this product or investment. That would be my recommendation.
Brad, thank you. Saira?
Very quickly,
Yeah.
I would say, from Laura Darcy's report about primary care, GPs and primary care practices are being asked to do so much more with the same funding or less funding and less staff. So it's a bit of a no-brainer for the centre and NHS England, etc., to invest in these communities. Primary care is the heart of the NHS. It's where the most number of interactions happen between patients and health and care staff. And beyond that, so it's so much more than just, you're going for your healthcare appointment, it's everything else beyond that as well. So, it's been a huge push in the recent report, and hopefully that will be enacted upon.
Great. Right, one final question from me, okay? AI, good or bad for health inequalities? You've got 10 seconds to answer.
Good. We're working on health literacy, so AI literacy, and therefore embedding it. It has to be for the good because the power of the technology is brilliant, but we also need to make sure we have regulation and we have knowledge wrapped around it. But also, it's the future, and therefore it's a Trojan horse to actually get funding for things like digital inclusion, surprisingly.
Okay, good, thank you. Brad?
Yes, it's only as good as the data input into it, so we need to make sure that that data input is equitable for everybody, so the answers that get back work for everybody. Very much like social media, though, social media and regulation and making sure that it's safe, it's like trying to put a saddle on a horse that's bolted. So before AI really bolts, we need to make sure that it is regulated in a safe way.
Thank you. Saira, final words from you.
Definitely good. It's the way forward. Let's be honest. AI is not the holy grail. It's not going to fix all our problems, but at the same time, we need to make sure we're using AI to fix our problems. And I think that's the way forward. We've got to make sure we've got data that's as good as possible. We've got a diverse range of inputs, and the way that we deploy it's got to be ethical, fair. Make sure we're looking at data privacy, security. And final thing is that we look out for those unintended consequences because we cannot worsen and deepen inequities.
Very good. Listen, thank you to our panelists.